Dear audience, this is my great pleasure to present you on behalf of my colleagues our project entitled Chronic Viral Hepatitis, HIV infection and non-Hodgkin lymphomas in West Africa through case control study. First of all, as a reminder, non-Hodgkin lymphoma, NHL, are important and underestimated cause of cancer in West Africa, where chronic viral hepatitis and HIV infection are highly prevalent. While the association between HIV infection and NHL has been well characterized, limited information is available on the relationship between chronic viral hepatitis and non-Hodgkin lymphoma in this region of the world. More precisely, although not classified as carcinogenic to humans with regards to NHL, there's a growing body of evidence supporting the association between HBV and NHL, but previous reports are usually not adjusted for HIV infection and prior exposure to chemotherapy known to reactivate HBV. And we have, of course, limited information from sub-Saharan Africa. Therefore, our objective was to document the association between chronic viral hepatitis, HIV infection, and non-Hodgkin lymphoma in Côte d'Ivoire and Senegal. To this end, a case control study was conducted in referral hospital of Abidjan and Dakar. Cases were matched with control. The diagnosis of NHL relied on the combination of a first local pathological examination combined by a centrally based diagnosis completed with a immunohistochemistry performed abroad. HIV, HBV, and HCV serology were systematically performed in controls and cases and prior to any chemotherapy. A conditional logistic regression model was performed to assess factors associated with NHL. Of the 150 participants eligible to be included in our case series, only 117 were effectively included. This translates into a 22% of participants being excluded based on immunohistochemistry. Our included population was mainly men with a median age of 50, and majority of participants were from Abidjan. Of note, no cases of co-infection was reported in our case series. With regards to histological subtypes, the most frequently reported subtypes was diffuse large B-cell lymphoma. Of note, a great proportion of T cells NHL was reported in our case series. When looking at factors associated with non-Hodgkin lymphoma, HIV serology, HBs antigen positivity, and HCV serology were all significantly associated with NHL in multivariable analysis. Based on our results, we can say that chronic viral hepatitis B and C were independently associated with NHL in West Africa. This supports timely preventive measures against HBV and HCV might prevent a significant number of NHL. Second, almost a quarter of false NHL diagnosis was reported based on immunohistochemistry. This clearly supports the crucial need of a better access to histochemistry in these low-risk settings. Third, we noticed a particularly high proportion of T cells, non-Hodgkin lymphoma, in our case series. And this raises a question with regard to the contribution of HTLV infection in NHL in this particular context in West Africa. Thank you for your attention, and thanks for the contributors, partnering institutions, and of course the funders, the NIH and NCI, NIAID. Thank you. Happy to take questions.